Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Substance Use and Substance Use Disorder in Older Adults, Focus on Rural Settings. And joining me today is Dr. Ramsey, Chief of Medical Services for New York State OASAS. But first, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Thanks so much, Dean. First of all, just to state, I do not have any significant financial disclosures, and we'll go ahead and get into our presentation. Our learning objectives for today discuss the epidemiology of substance use disorder in the 55-year-old and older population with a focus on opioids, alcohol, cannabis, and overdoses. Discuss barriers to substance use disorder care for older adults. Discuss best practices, stigma, language, trauma, and screening in this patient population. Discuss having meaningful discussions around substance use and practical interventions. So first, we're going to go into the epidemiology of substance use and substance use disorder in older adults. First, an overview of substance use among older adults. On the left-hand side, you can see some data from the National Survey on Drug Use and Health from 2021. As you can see, the past month alcohol use is the highest among adults aged 50 years and older, followed by tobacco product use and or vaping use, followed by cannabis use. The populations or the numbers using other substances are much smaller than the top three of alcohol, tobacco, or cannabis. Some information from SAMHSA Tip 26, which is looking at substance use in older adults, is noticing that the rates of substance use and substance use disorders are increasing among older adults. I'm just going to focus on the highlighted points here. However, the rest of the information with more detail is also on this slide. So older adults have fewer social supports and increased social isolation compared to their younger counterparts. Caregivers, families, and healthcare providers have difficulty differentiating between substance use disorder, cognitive decline, and mood issues in older adults. Often there's a conflation of symptoms, and you have to do a little bit more investigation to tease out the difference between these symptoms. Alcohol, as I mentioned, remains the most used and misused substance among older adults aged 50 and older. There are multiple studies that are showing increasing rates of medical and recreational cannabis use among adults aged 50 and older. One study found that between 2006 and 2013, cannabis use among adults aged 65 and over rose 250%. And then according to the National Survey on Drug Use and Health in 2021, 11.3% or 13.4 million people reported having any substance use disorder in the population 50 years and older, and 7.6% or 8.9 million people in that age group reported having an alcohol use disorder specifically. So let's do an overview of substance use among older adults. So first, I'm going to talk about non-medical use of prescription medications and risks for opioid misuse in older adults. So at least 1 in 4, or about 25% of older adults, use psychoactive medications with misuse potential. These include medication classes such as benzodiazepines, opioids, antipsychotic medications, and what we call the Z medications, which would include zolpidem or name brand Ambien, and others that are similar in that class. That have significant health consequences. So in other words, 1 in 4 older adults who use these psychoactive medications end up having significant health consequences from their use of these medications. Some of those complications can include impaired cognition, overdose deaths, falls, which have significant morbidity and mortality in the older adult population, motor vehicle accidents, and reduced efficacy of other medications that they take for other chronic health conditions such as insomnia and PTSD. Factors associated with prescription medication misuse in older adults include female gender, social isolation, a history of substance use or a mental health condition or diagnosis, and medical exposure to prescription medications with misuse potential. So that would include some of the psychoactive medications that I listed above. Older adults are often on more prescribed medications than younger adults, or what we would call quote unquote polypharmacy, which may result in more medication substance interactions in older adults. So for example, interaction with alcohol or cannabis or other substances they may be using. There are increased rates of opioid use disorder, overdose deaths, and suicide rates in older adults. In fact, African American males over age 55 are the highest risk population for overdose in New York State, New York City, and nationally. Only 10% of opioid treatment resources nationwide are located in rural areas. Again, we're doing a focus on older adults in rural areas in this presentation. And only 11% of patients seeking opioid use disorder treatment in rural areas are able to receive medications for opioid use disorder. Specifically, we're referring to methadone and buprenorphine, which, as we know, are life-saving for individuals with opioid use disorder. On the right-hand side, you can see some more statistics. So about 78% of older adults in the United States who drink alcohol also take medications that interact with alcohol. 3.7 million adults age 65 and older used illicit substances in 2019. Cannabis is listed as an illicit substance here. However, again, in New York State, it has become legalized. Next, we're going to look at prescription medication use among older adults. On the left-hand side, we're looking at data, again, from the National Survey on Drug Use and Health from 2021 in adults age 50 and older. So the blue bars are showing the individuals who are 50 years and older, and the red bars are showing those that are 60 years and older. So here we're looking at past year use of prescription pain relievers. So you can see that they are pretty commonly used in this patient population. Next is past year prescription tranquilizer or sedative use. Again, less commonly used than opioids, but still pretty commonly used. And finally, past year prescription benzodiazepine use, which again, about 1 in 10 individuals in those age groups are using benzodiazepines. So we know that older adults are particularly vulnerable to misusing prescription medications for some of the reasons that I listed on the previous slide. The medications of most concern are due to potential negative health impacts are psychoactive medications that affect the central nervous system. So if you're talking about a population that may have social isolation, may have mental health conditions that may or may not be being treated, as well as some cognitive decline, and then you're adding medications that have effects directly on the central nervous system or the brain, you're talking about a potentially dangerous combination. So in other words, these medications can interact with substances, including alcohol, cannabis, etc., that can potentiate their effects on that individual. There are geographical differences in prescribing patterns and in the opioid epidemic. So on the left-hand side is showing some data from 2017. It's a little difficult to read, but it's showing the very different prescribing patterns across the United States. Those that are in red are states that have the highest rates of opioid prescriptions. Those with green are the lowest rates of opioid prescriptions that are written. And then in the middle, you see variations of yellow to orange to darker orange. So New York actually falls at the lowest where healthcare providers are prescribing opioids, but you can see that depending on where you live in the United States, your access to prescription opioids is going to be different. On the right-hand side are some facts about the opioid epidemic, specifically in rural America. So opioids are the most frequently prescribed type of medication in the United States. In fact, in the United States, despite having not a high percentage of the world population, we consume 90% of the prescribed opioids, oxycodone and hydrocodone, in the United States. So in other words, we have a highly disproportionate consumption of prescription opioids in the United States compared to the rest of the world. Next, drug-related deaths are 45% higher in rural areas than in urban areas, and rural Americans are twice as likely to die from opioids than their urban counterparts. Adults age 45 and older accounted for 43% of rural opioid deaths in 2016. So continuing with our overview of substance use in older adults, what are some issues that are unique to older adults with substance use? First and foremost, there are age-related changes in the absorption and metabolism of both medications as well as substances that they may be using that are acquired from the unregulated drug supply. So again, a person may use substances at a time earlier in their life. However, as an older adult with these age-related changes in kidney function, sometimes in liver function, and the way that we process medications, including medications that are lipophilic, so that the proportion of fat tissue is very different in older adults compared to younger adults. All of those physiological changes cause the absorption and metabolism of both medications and substances to be very different for older adults. And older adults may not be expecting that, so they may have impacts that they're not anticipating. You also have interaction of medical conditions, so whether that's a chronic heart condition or a chronic kidney disease or compromised liver function due to cirrhosis, for example, as well as cognitive impairment, functional impairment. So if someone's taking a benzodiazepine, is at higher risk for fall and already is using an ambulatory device. Again, all of these interplay with one another, as well as having underlying mental health diagnoses and perhaps a substance use disorder already diagnosed or a substance use disorder not yet diagnosed. Frequent use of multiple medications, both for chronic medical conditions as well as for mental health and substance use disorder. Goals of care play a larger role in healthcare decisions, and loss and grief are common. So many folks who are older adults have lost a spouse or family members, etc. So how does the opioid crisis differ for rural older adults? I mentioned a few stats a couple slides back on the opioid crisis in general in rural America, but let's specifically look at older adults in rural America. So first, if we look at demographics, rural populations tend to be older than in urban areas. More than 16% of the nation's 48 million rural Americans are over age 65. Rural areas also have a higher proportion of those aged 85 and older who are more likely to have chronic medical conditions and disabilities. There are economic factors. There's low income in rural areas. There's higher unemployment rates and often substandard housing conditions. So rural poverty rates are significantly higher among Blacks or African Americans. So 36.9% live in poverty. Among American Indians or Native Americans, at 33% live in poverty, and Hispanics or Latinx population, 27.5% live in rural poverty. With respect to unemployment, research shows that the unemployment rate in rural areas consistently exceeds the national average, and combined with poverty and limited educational opportunities, creates a cycle of socioeconomic depression. With respect to education, health literacy is a big issue in opioid misuse, and folks may not have access to as many resources in a rural area as they do in an urban area. With respect to social factors, rural older adults live in close-knit communities in which some tend to accept self-medication and drug sharing. There's often multi-generational drug sharing, yet place a stigma on addiction or treatment for substance use. So again, there may be increased stigma towards individuals with substance use and substance use disorder and towards things like medication for opioid use disorder, yet it is common to have multi-generational drug sharing and medication sharing. And with respect to health conditions, older adults in rural areas are prone to more chronic pain, depression, and social isolation compared to their urban counterparts. So substance use disorders among older populations, what role do race and ethnicity play in treatment and treatment completion? So this is a study that came out in January of 2022. I'm just going to focus on the highlights here. So in this study, they found that substance use treatment admissions for people aged 50 and older were persistently increasing over the time of the study. Their findings also indicate that on average, Black individuals relative to white individuals with respect to admissions to substance use treatment across all age groups were less likely to complete treatment and more likely to have their treatment terminated by a treatment facility. So again, when we're thinking about that, are our systems responsive to the individual needs, and are they culturally responsive to different groups? In other words, if folks are leaving from a particular racial or ethnic group, are leaving treatment more often or having their treatment terminated more often, we need to think about what role is systemic racism playing in that treatment facility or within the treatment system itself. They also found some evidence that Hispanic or Latinx admissions were relatively less likely to complete treatment across all age groups, and Latinx individuals over 50 years old were also more likely to terminate treatment. So again, the same questions as I asked with respect to Black patients, we need to ask about all racial ethnic groups when there are disparities. So lastly, they found that males relative to females were more likely to complete a substance use treatment program, but no more likely to have their treatment terminated by a substance use treatment facility. So again, we would have to ask the same question: are our treatment facilities meeting the needs of female patients, having, for example, a women-only track in programming, et cetera, to answer the question of why are they completing treatment less often? Or does it have to do with childcare issues, transportation issues, and other issues which uniquely impact women more significantly than men? Looking at opioid use disorder and treatment, these are rural-urban comparisons. On the left-hand side is looking at population-adjusted emergency department visit rates per 100 people. And so what they found is that visits to an emergency department for opioid use disorder or post-overdose are much higher in rural areas than in urban areas. And on the right-hand side are opioid-related visits per 100,000. And you can see that you have more urban visits for opioid-related issues rather than you see in rural areas. This is looking at rural and urban variations in the association between substance use and pre-hospital crash injury severity among older adults. And this was a single-year study. So I'm just going to focus on the highlights here. So the background was that the study was aiming to assess the rural-urban differences between substance use and crash injury severity among older adults. So they stratified individuals by rural setting versus urban setting. And what were the results that they found? Substance use was reported in approximately 4% of the sample population, and this proportion did not significantly differ across rural versus urban areas. After controlling for patient and injury characteristics, though, substance use was associated with 45% increased odds of emergent, critical, and fatal injuries compared to low acuity injuries across all areas. The predicted probabilities of critical and emergent injuries increase from urban to suburban to rural areas. So in other words, if you're using a substance and you're involved in a crash, you're far more likely to have very severe or critical or fatal injuries if you live in a rural area compared to an urban or a suburban area. So their conclusion was substance use is associated with worse geriatric crash injury severity, and the predicted probabilities of substance use related emergent and critical crash injuries increase from urban to rural areas. This was looking at substance use treatment services for older adults in 5 states in the southern United States, a state-by-state comparison of available treatment services. So their objective in this study was looking at substance use disorder among older adults, recognizing that it's become a serious public health concern, and how available is treatment specifically for older adults, and they were looking in the southern United States. So what were the results that they found? Of the 1,215 facilities that they looked at, only 20% indicated that they had programs specifically tailored for older adults. And their conclusion was that across the United States, most adults with substance use disorder do not have access to substance use treatment. In this study, it was particular to the southeastern region of the United States, but often in areas that have higher poverty rates, rural geography, and increased stigma, there's a lack of treatment availability. And so this can complicate the medical care that individuals receive for their substance use or substance use disorder. This study came out in November of 2022, is looking at patterns in geographic distribution of substance use disorder treatment facilities in the US and accepted forms of payment from 2010 to 2021. So again, breaking down the important points of this study. So why were they looking at this issue? They were trying to understand the geographic accessibility of substance use disorder treatment facilities accepting Medicare. So again, we know that in the United States, most individuals over 65 use Medicare as their form of payment for their medical care. So they were trying to figure out what treatment facilities for substance use disorder specifically accept Medicare, and is that a feasible payment option for older adults to access treatment? So their objective was to assess whether geographic accessibility of services was limited for older adults despite the increasing need for substance use disorder treatment in this patient population. So they looked at the measures that they used included the national proportion of treatment facilities accepting Medicare, Medicaid, private insurance, or cash as a form of payment, the proportion of counties with a treatment facility accepting each of those forms of payment, and the proportion of the national population with Medicare, Medicaid, and private insurance or cash payment residing in a 15, 30, or 60-minute driving time from an SUD treatment facility that accepted their form of payment in 2021. So what were the results that they found? Cash was the most commonly accepted form of payment, and that was followed by private insurance, and then Medicaid, and then Medicare. So ultimately, the conclusion of this study was that the study suggests that Medicare beneficiaries have less geographic access to SUD treatment programs. And given that the acceptance of Medicare was low compared to other forms of payment. So what they suggested is that policymakers need to consider increasing reimbursement rates and using additional incentives to encourage the acceptance of Medicare. So you can see how far behind Medicare acceptance lagged. It's the line on the bottom in comparison to cash, private insurance, and Medicaid. So obviously, this makes treatment highly inaccessible. In addition, the distance to treatment facilities, this is coming from the same study, varied again by payment. So on the left-hand side is showing percentage of counties with a substance use disorder treatment facility who accepts Medicare versus the others. Again, Medicare is the line on the bottom, so you can see that there are very few counties that accept it. And then if you look at the graphic on the right-hand side, it's showing the driving distances that people have to drive to get access to treatment. And so it's broken down by 15 minutes, 30 minutes, and 60 minutes. But many parts of the United States, individuals would have to drive 60 minutes or more. That's the purple and the yellow to try to access treatment that was close to them. So again, that makes it highly inaccessible for many rural older adults. We're going to transition and look at some data around drinking. So this is looking at the prevalence of binge or heavy drinking among New York State adults by sex, race, ethnicity, and age. And this is 2020 data. So again, you can see it broken down by its binary gender, male or female, by race, ethnicity, white, black, other race, and Hispanic or Latinx, and then by age group. So among adults 55 and older, so the 55 to 64 population is 13.7%. Engaged in binge drinking in 2020, and among those 65 years and older, 8% engaged in binge or heavy drinking. So some data came out recently, an article in 2022 about deaths attributable to excess alcohol use, and this was an adult population aged 20 to 64. So they looked at adults' deaths that were attributable to alcohol. So they used 55 causes defined by the CDC. So in this study, approximately 2.1 million recipients in the time period of 2015 to 2019 in this, the BRFSS study, so the Behavioral Risk Factor Surveillance System. In that group, approximately 695,000 deaths occurred among adults aged 20 to 64. Of those, 12.9% or 89,700 deaths per year were attributable to excess alcohol consumption. So that was 1 in every 8 deaths in the patient population aged 20 to 64. If you break that down further and look at a younger population, 20.3%, 45,000 of deaths per year among those aged 20 to 49. So it actually, alcohol attributable deaths account for 1 in 5 deaths among those 20 to 49 years old. This is looking at that same data by state. And so you can see, again, there's variability depending on where you live geographically. The highest rates of deaths attributable to excess of alcohol use are in the states in the darker color. So New York actually is in lower percentage comparison to particularly in the Rockies and in the northwest west part of the country. This is data also from that study breaking down the rate per 100,000 population. So in the 50 to 64 population, the rate per 100,000 is 70.8 for excessive deaths due to alcohol use. And again, that's the highest in comparison to other age groups. Part of that is due to the chronicity. So individuals who have been drinking excessively for a long period of time are more likely to have the health consequences accumulate over time. So for example, individuals with cirrhosis it's not unexpected that they would be in that older age group, but it is quite significantly a higher rate than the other age groups. This is a study that came out during COVID-19. So this was looking at alcohol-related deaths during the COVID-19 pandemic. So this was data in looked at 2019 to 2020, and into early 2021. So the compared rates of alcohol-related deaths on all-cause deaths among individuals aged 16 and above in 2019 and 2020. Deaths from all causes increased 18.8%, and the number of alcohol-related deaths increased 25.5% between 2019 and 2020. This is, again, more details from that same study. So the number of deaths involving an underlying cause of alcohol-associated liver diseases increased by 22.4% during that time period. And again, highly impacted is that population over 55. This is data from the National Survey on Drug Use and Health from 2019, as well as a JAMA article that was published in 2021. So in 2019, the National Survey on Drug Use and Health was the first survey that asked if those who received past year treatment for alcohol use disorder were prescribed medication. So we have 3 FDA-approved medications for the treatment of alcohol use disorder: acamprosate, disulfiram, and then 2 formulations of naltrexone, the oral formulation as well as the long-acting injectable formulation. Despite having 3 FDA-approved medications for the treatment of alcohol use disorder, they're unfortunately highly underutilized. So according to the 2019 National Survey on Drug Use and Health data, there were 14 million individuals, or 5.6% of the population, met past year alcohol use disorder criteria. 1 million, or 7.3%, received any alcohol use disorder treatment in the past year. So again, a very small amount of individuals diagnosed with alcohol use disorder actually accessed treatment. And of those that received treatment, only 223,000, or 1.6%, reported using a medication to treat alcohol use disorder. So the rates in New York State are slightly better than this. Depending on where you live in the state, it varies from about 4% to about 9 or 10% of the population diagnosed with AUD are actually on treatment for AUD with a medication that's FDA approved to treat alcohol use disorder. I'm going to shift over to cannabis and older adults. So this comes from an article published in 2021. So what we saw over time was a decreasing perceived risk associated with regular cannabis use among older adults in the United States from 2015 to 2019. So they used data from the National Survey on Drug Use and Health between 2015 and 2019. It included approximately 19,000 adults 65 years or older. The question was, how much do people risk harming themselves physically and in other ways when they smoke cannabis once or twice a week? And it focused on the change in those who responded great risk. So you can see how that number changed over time. So that older adults are perceiving decreased risk associated with cannabis use. So what are the trends in cannabis use among older adults in the United States? So this is from data from 2015 to 2018, analysis of approximately 15,000 adults 65 and older from National Survey on Drug Use and Health. It estimated the prevalence of past year cannabis use, and they defined cannabis as including marijuana, hashish, other terms such as pot, grass, or hash oil, and it was by smoking or by ingestion. And you can see that that number steadily increased between 2015 and 2018. So cannabis, an emerging treatment for common symptoms in older adults. This is from a study that was published in 2021. This is an anonymous survey of almost 600 adults aged 65 years and older, and it was trying to assess the characteristics of their cannabis use. The study took place at a geriatric clinic in San Diego, California, over a period of 8 weeks. And again, recreational cannabis is legal in California, as is medical cannabis available. So 83 survey respondents reported cannabis use within the past 3 years, and compared with those who used cannabis within the last 6 months to those who used cannabis between 3 years and 6 months prior. So here were the findings from that study. 75% found cannabis somewhat or extremely helpful. 61% of respondents used for the first time as an older adult. So again, we talked about the physiological changes that happen in older adults. So 61% of the respondents in this survey had never used cannabis before they were 65 or older. So again, maybe unexpected effects that may be very different from younger individuals using cannabis. Compared to those who had used in the past, those who used cannabis for the first time as an older adult were more likely to be older. 50% were in the 75 to 84-year-old age group. Using CBD only products, so again, no THC, so no psychoactive component, were 57% of those individuals. Using for medicinal purposes only, 94%. Used in ways other than smoking or vaping, 45% used lotions, 41% used tinctures, 14% used pills or edibles, and only 10% smoked and 12% vaped. This is data that's from the National Survey on Drug Use and Health from 2021. This is looking at past year substance use disorder, any mental health diagnosis, and a serious mental health diagnosis looking at adults, so aged 18 and over. On the left-hand side, you see the intersection. In yellow is adults that have any mental health diagnosis. In blue are adults that have any substance use disorder diagnosis. And the intersection of the two with comorbidity between any mental health diagnosis and a substance use disorder diagnosis is in the green. On the right-hand side, you see in red adults with a serious mental health diagnosis, and then in blue, adults with a substance use disorder diagnosis, and then the intersection of the two, adults with both a substance use disorder and a mental health diagnosis. So as you may notice, there are far fewer adults with a serious mental health diagnosis than there are with any mental health diagnosis. And there's a larger intersection between adults with any SUD diagnosis and having that comorbidity of any mental health diagnosis. But among the population with a serious mental health diagnosis, a vast majority of that population also has a substance use disorder diagnosis. So again, there is comorbidity between the two, but it's not uniform. And that comorbidity looks differently if someone has any mental health diagnosis versus a serious mental health diagnosis. We're probably all really familiar with these data, but I think it's just important to frame it again as part of this discussion. So this is looking at overdose deaths pre-COVID-19. On the left-hand side is showing all national, so U.S. national drug-involved overdose deaths among all ages between 1999 and 2019. And leading the pack is that orange-looking line, which represents synthetic opioids. So that's specifically referring to illicitly manufactured fentanyl and its analogs. On the right-hand side is showing drug overdose death rates, again, by national data between 1999 and 2017. So broken down by age groups, and you can see leading the pack is the age group of 45 to 54-year-olds for the majority of that time period. They were surpassed by the 25 to 34 and 35 to 44-year-olds in light of the current fentanyl epidemic. But you can see that even among older populations, 55 and 64-year-old, and then 65 and older, in every age group, overdoses are increasing over that period of time. So what about older adults and overdose specifically? So rates of overdose and overdose death are rising significantly among older adults. That's true both in New York State as well as nationally. A study of national opioid overdose deaths found that for adults aged 55 years or older, annual rates of opioid overdose deaths per 100,000 persons increased from a rate of 0.90 in 1999 to 10.70 in 2019. And among those overdose death rates, there are significant disparities. So this particular study was looking at disparities by sex and race and ethnicity in death rates due to opioid overdose among adults 55 or older between 1999 and 2019. So it's the same study that we looked at on the prior page, but this is breaking it down again by race, ethnicity, and sex. So in 2013, rates among non-Hispanic Black men began to diverge from those of other demographic subgroups. By 2019, the opioid overdose fatality rate among non-Hispanic Black men 55 years or older was 40.03 per 100,000 population, 4 times greater than the overall opioid overdose fatality rate of 10.70 per 100,000 for persons of the same age. So that blue line that has that very sharp peak going upwards represents African American males over 55. What about New York State specific overdose mortality data? So as we know, just like they are nationally, overdose deaths are rising. And in 2021, the total number of overdoses topped 107,000. The data that we have, preliminary data for 2022, shows that that rate has topped 109,000. That's not finalized data yet. According to the Kaiser Family Foundation, which is a nonprofit in California that does a lot of research around substance use, adults age 55 and older accounted for only 5% of New York's total opioid overdose deaths in 1999, but they accounted for 24% of those deaths in 2020. So again, it's really focused on Black men age 55 and older, and New York City and New York State both demonstrate this pattern. So when we think about substance use disorder, there are many, many vulnerabilities for people to develop a substance use disorder. So on the right-hand side, I have a graphic showing how those factors interplay with one another. So there are genetic factors, there are environmental factors, which include social influence and availability, as well as biochemical and behavioral factors. So I think a lot of the vulnerability is due to genetic predisposition, which I think many people don't realize just how much of the vulnerability or risk comes from genetic predisposition. So if there is any history of any substance use disorder in a family tree, and that includes tobacco use disorder as well as any other substance use disorder, that confers 40 to 60% of the risk or vulnerability of developing a substance use disorder. That variability is based on the substance. So the rates for cocaine use are even higher. It's up to 70% of the genetic predisposition for cocaine use disorder. So what are some of the other factors that play a role? We've talked about concomitant mental health diagnoses, but it's not mental health diagnoses in general. It really is targeted on specific diagnoses. Those include bipolar disorder, any anxiety diagnosis. So that could include panic disorder, PTSD, social anxiety, major depression, ADHD, specific personality disorders such as borderline and personality disorder and antisocial personality disorder, antisocial conduct disorder, which is typically diagnosed in adolescence, eating disorders, and there's variability among different eating disorders with respect to the amount of risk. And again, this is whether folks have this diagnosis or they have not yet received the diagnosis. They may be treated or untreated. But again, these particular mental health diagnoses do confer increased vulnerability. So a history of trauma and or abuse. So for females, this is typically pre-adolescent sexual trauma. For both males and females, being a victim to or a witness to violence. So think about adverse childhood experiences. Many of those formative experiences that happen early in someone's life have a profound impact and contribute to that vulnerability later to develop a substance use disorder. Also think about particularly impacted communities with respect to trauma. So the LGBTQIA+ community and the BIPOC community. So poor coping mechanisms can play a role. So substances are used to cope. So it can be escapism from trauma or negative feelings, and it's harm avoidance. So things that we think of as risky behaviors really are coping mechanisms for individuals who may be dealing with mental health symptoms or having trauma memories, for instance. Impulsivity plays a role in the initiation of substance use. So particularly with certain mental health diagnoses like bipolar disorder or borderline personality disorder, there is increased impulsivity associated with those diagnoses. And also the brain that is not well developed until about 25 years old with respect to the prefrontal cortex, which is also associated with increased impulsivity. So again, until we're about 25, the prefrontal cortex is not sufficiently developed enough to really be able to weigh consequences of actions and be able to have delayed pleasure or delayed reward. Sensation and novelty seeking may play a role in the initiation of substance use. Environmental triggers and sensory cues are very significant for being triggers to use or resume use. And then the formal definition is a lack of homeostatic reward regulation or reward deficiency. So when we use substances, particularly early, then we become disproportionately oriented to exceedingly pleasurable rewards. The dopamine surges that come from substances are not comparable to the normal dopamine surges that we get with pleasurable activities in our life, such as eating something that we like, or sex, or other pleasures. So again, a dopamine surge from methamphetamine cannot be physiologically matched by anything that we do in our normal course of life. So by using substances early on, we are priming the brain and actually making physiological and anatomical changes in the brain that to lead us to be more vulnerable to ongoing substance use. So this slide is really challenging to read, but these are risk factors for substance use. On the left-hand side is showing the social ecological model for human development and the factors that play a role in that. So you are in the center, and then it spirals out with the factors that play a role in your life. And so it's very complex when we think about substance use and the risk factors for developing it, because it's so multifactorial. It's not a linear process. And so some examples of risk factors for substance use are listed on the right-hand side. I'm not going to go through these in detail, but there's a community role, there's a family role, there's a peer and other influence role, and then there's an individual role. So there are multiple factors at multiple levels that play into increased risk factors for substance use, or on the opposite side, protective factors from substance use. So let's talk about some barriers to care for older adults. So there are many significant barriers to care for older adults. So they often face numerous barriers, so not a single barrier to accessing substance use disorder treatment. And these are the same barriers that may create additional challenges for providers attempting to coordinate care across multiple systems of care. So I'm going to just mention some of these examples. So there's stigma, which I think is the biggest barrier of all. So stigma towards substance use, but also ageist assumptions about older adults and substance use. So some examples are listed here. No treatment is needed, let them just use, they won't benefit from treatment, etc. Lack of routine screening for substance use disorder, and that includes for all populations, but there's probably an added element of ageism. So older adults don't use substances, that plays into that. So in most healthcare settings, SUD is not being screened for routinely or using a validated screening tool. There's a lack of provider education about substances, substance use disorder, and substance use disorder treatment. There's barriers to medication access. There's housing instability or being unhoused. Insurance barriers, we talked about Medicare already, and cost. medical and mental health comorbidities that may make it more difficult to recognize substance use and substance use disorder, but also may create barriers to accessing care if their medical conditions or their mental health conditions affect their ability to engage in substance use disorder treatment. A lack of accessible transportation, especially for older adults with limited mobility, social isolation and lack of social supports, lack of culturally responsive, so age-appropriate SUD treatment programs, skilled nursing facility or long-term care facility resistance to caring for individuals with opioid use disorder. So the Department of Justice did release the Americans with Disability Act guidance document specific to this topic, and I've put the link there if people want to access that information. And then limits of reimbursement models. So again, we talked about Medicare on an earlier slide. So there are specific barriers to substance use disorder treatment services for rural populations. So again, there are multiple different barriers at different levels. So there are fewer facilities, which we saw in the study that we looked at a few slides ago. There is less anonymity in small communities. So that may be a barrier. There are just lower treatment access in general to different options. There's limited public transportation. There are fewer addiction treatment professionals in those communities, and often increased stigma in rural communities. This particular study, it's a little bit of an older study, but I still found it interesting. It's from 2014. So this was a study looking at treatment use, perceived need, and barriers to seeking treatment for substance use and mental health problems among older adults compared to younger adults. And so what they were trying to figure out is it more challenging for older adults to access substance use and mental health treatment? So what they found in the results was that the age group of 65 plus was least likely to use treatment and perceive treatment need, but the 50 to 64-year-old age group was more similar to the younger age groups than the 65 plus age group. Controlling for age and other predisposing and enabling factors, alcohol and other substance use disorder treatment and comorbid mental health conditions increase the odds of SUD treatment use. So if a person had comorbid substance use disorder and mental health diagnoses, they were more likely to access SUD treatment. And of mental health issues, anxiety disorder had the largest odds of somebody seeking mental health treatment for it. And so what they found when they did further analyses was that it showed a lack of readiness to stop using, and cost or limited insurance were the most frequent barriers to both SUD and mental health treatment among likely adults. And they were less likely than younger age groups to report stigma or confidentiality concerns with respect to mental health treatment. So what are some potential solutions to barriers for older adults? So specifically for methadone, when we think about COVID-19 and the SAMHSA flexibilities with respect to take-home doses, which have been extended for the moment and likely will be made permanent with rules that have been proposed by SAMHSA, extended take-home flexibilities for methadone treatment is a great option for older adults. Another option for OTPs is having a designated other. So if that older adult has difficulty making it physically to the OTP because of either mental health or medical comorbidities, then they can have a designated other to pick up their medication at the OTP. That could be a family member, a trusted neighbor, a friend, etc. Utilization of telehealth, so audio-visual telehealth or audio only, initiations for buprenorphine and other substance use disorder services. Again, keeping in mind, making sure that that person feels adept at the technology involved in telehealth if that service is being offered to the older adult. Coordination with Medicaid or other forms of transportation, medication delivery services, mobile medication units or MMUs for initiation and continuation of both methadone and buprenorphine, Potential additional federal regulatory changes and flexibilities, which may be made permanent. Removal of the X waiver to prescribe buprenorphine. So now any prescriber in the United States with a DEA can prescribe buprenorphine. There are no specific requirements to do so. Actively working on stigma reduction and routinizing screening for substance use disorder in all adults with a validated screening tool. What are some considerations for care coordination? So it's important to integrate assessing for and developing solutions for possible barriers throughout the treatment process. So we don't want to be stymied when a barrier appears and have to try to scramble to figure out how to correct it. We want to be proactive and think about the possible obstacles that could occur for our older adult that we're working with. So we want to be able to identify local substance use disorder prevention, harm reduction, treatment, and recovery services and begin developing rapport with them. We don't want to wait until we need to refer someone to a particular service before we build those relationships. Obviously, people can always reach out to the local OASAS regional office for assistance. We want to model using destigmatizing language when discussing substance use with individuals, their families, and social supports, and other community providers, and focus care coordination activities on the client's expressed goals and preferences, and emphasize individualized shared decision-making and choice throughout the care coordination process. What is the role of the family in treatment and care coordination? So family members, caregivers, and other social supports are important allies for both care coordination and substance use disorder treatment in general, and specifically for older adults. Research shows that family, social supports, and community resources are integral to successful long-term recovery for people with substance use disorders across the lifespan, so including older adults. Family and other social supports can often fill in the gaps to bridge systems of care that may not be well coordinated. So as an example, when we talked about designated others on the previous slide, family members can act as designated others and pick up methadone from an OTP or opioid treatment program on behalf of an older adult resident who may be living in a care facility, for instance. So a reminder that consent is critical for family engagement. So always get patient consent before engaging family or loved ones in care coordination, and empower the client to decide with whom information is shared and what information specifically can be shared. How can we engage families in older adult care? So we want to approach this as a collaborative process. Obviously, the older adult should identify who in their family that they would like to assist with treatment. And then on the opposite side, the family member needs to be willing and able to assist with that treatment. Remember that stigma towards substance use, harm reduction, and medications for opioid use disorder may pose barriers to engaging families. So we want to validate the family's feelings, but provide fact-based, evidence-based psychoeducation on harm reduction, on substance use, and on medications for opioid use disorder. So that's an extremely important part of the process. It empowers them to be better support for their loved one who is in care. So again, model anti-stigma language when interacting with clients and their families. Use person-first language, so a person with a substance use disorder instead of addict or alcoholic. Use the term recurrence of use instead of or return to use instead of relapse. And there are many, many resources available for appropriate language when talking about substance use. And families also may need to be connected to supports for their role in their older adults' care plan. So we're going to focus on best practices with respect to stigma, language, trauma, and screening in the older adult population. So first, best practice is to ask about substance use. So assume drug use is occurring, normalize it. We always want to ask non-judgmentally with curiosity. It's extremely important to be aware of your face and your tone of voice. don't necessarily expect people to be honest with you at first. You have to earn that trust over time. If people don't know you well enough, they're afraid of being stigmatized, and so they're not likely to be honest with you initially. Most importantly, listen. So everyone has a story, and we certainly get to know our clients or patients better and develop empathy for them if we listen to the story of how they got to where they are in their life. So just a reminder, the USPSTF, or the U.S. Preventive Services Task Force, recommendation for all adults in primary care is recommending screening by asking questions about unhealthy drug use in adults aged 18 or older, and that's recommended to do yearly. So again, this is with a validated screening tool. This is not taking a urine toxicology specimen. That is not a way to diagnose substance use or substance use disorder. So what is the best practice? What are the NIAAA, or National Institute on Alcohol? Unfortunately, they have not changed their name yet. Hopefully they will soon. National Institute on Alcohol Abuse and Alcoholism. So again, using old language. What are their recommendations for alcohol use in older adults? So the recommendations are that healthy adults over the age of 65 who do not take medications should not consume more than 7 standard drinks per week, or 3 standard drinks on any given day. What is a standard drink? That is defined as 1 12-ounce can or bottle of regular beer. So again, a low APV, or alcohol content percentage, probably about 5%. So regular beer, ale, or wine cooler. An 8 or 9-ounce can of or bottle of malt liquor. So again, malt liquor has a higher percentage of alcohol content. 1 5-ounce glass of red or white wine, 1 1.5-ounce shot glass of a distilled spirit. Some examples are gin, rum, tequila, vodka, whiskey, etc. Best practice is a single question screening test. So a single question screening test for unhealthy alcohol use is: how many times in the past year have you had 4 or more drinks per day? And a response of greater than 1 is positive. A single question screening test for drug use. The question is, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? A response of greater than or equal to 1 is considered positive. If that single screening test is positive, you want to use a more detailed assessment tool. So the SMAST-G is specifically for alcohol. It is a 10-question screening instrument for alcohol use that is validated for use in older adults. The TAPS, the Tobacco, Alcohol, Prescription Medication, and Other Substance Use tool, is a screening instrument developed by NIDA that can be self-administered or administered by a clinician. It is not validated specifically in older adults, but it is validated in adults. Again, we always want to use a validated screening tool. What is the best practice for discussing cannabis use with older adults? If an older adult wants to talk about cannabis or cannabis products such as edibles, lotions, etc., you want to employ a non-judgmental, person-centered approach. Listen actively to understand what the symptoms are that the older adult is trying to alleviate. Remember that in that survey that we looked at many slides ago, about 95% of older adults were using cannabis for what they were calling a medicinal purpose. Engage the older adult in a discussion about the evidence of the risks of using cannabis based on the individual's history and current medical issues and medications, and offer alternative treatments to cannabis and cannabis products for their symptoms as appropriate, and provide referrals as needed. When discussing cannabis use, also give them harm reduction strategies for using cannabis or cannabis products. So use cannabis or cannabis products only when nothing important needs to be accomplished, like work obligations. Avoid non-prescription synthetic cannabinoids. So despite the similarity in the name, synthetic cannabinoids are created. They're basically chemical substances that are sprayed onto plant material that is not cannabis, and those are sold in things like bodegas and corner stores, and they are labeled not for human consumption and often labeled as incense and other similar products. OASAS has a webpage on synthetic cannabinoids with more detailed information, and we will be recording a Learning Thursday on synthetic cannabinoids in the near future. Avoid using over-the-counter CBD-only products or use only with extreme caution because they are poorly regulated or really not regulated at all. So we really don't know what is in them. Use higher CBD, lower THC cannabis strains or products. So just as a reminder, CBD does not have a psychoactive component. THC is the component that affects the brain and causes euphoria and other effects due to cannabis use. Do not use cannabis or cannabis products and operate a motor vehicle or heavy machinery. Do not mix cannabis or cannabis products with other substances, particularly sedating ones such as alcohol or benzodiazepines. Safely store cannabis and cannabis products in a lockbox or other locked containers so that you keep it away from children and companion animals such as cats, dogs, etc. Just to level set, how do we define stigma? It is the experience of being deeply discredited or marked due to one's undesired differentness. To be stigmatized is to be held in contempt, shunned, or rendered socially invisible because of a socially disapproved status. When someone views another in a negative way because they have a distinguishing characteristic or personal trait that's thought to be or actually is a disadvantage, so a negative stereotype. So unfortunately, the typical reaction to people who use drugs in the United States is to stigmatize them, stigmatize the person who's using drugs, stigmatize the substances themselves, and stigmatize individuals with a substance use disorder. We encounter stigma in many healthcare settings, unfortunately. So we defined stigma on the previous page, and that can happen at multiple levels. So within a healthcare setting, it can occur at the individual level, so person to person, at the group level, at the organizational level, or at the system level. And this can lead to prejudice and discrimination against people with mental health diagnoses, substance use disorders, and other diagnoses that are also marginalized, such as HIV and hepatitis C. Unfortunately, stigma perpetuates stereotypes and assigns inaccurate labels to people such as dangerous, non-compliant, manipulative, drug-seeking, dirty, at fault, etc., which obviously lead to poor treatment of them. So these phrases and statements and labels and the stigma in general can all be internalized by the person experiencing it to make them feel that they are not deserving of being treated with dignity and respect. And this can lead to further shame, fear, and isolation. So it makes them feel unworthy of seeking or receiving services, and it limits their ability or desire to access services. So we know that stigma leads to suboptimal and sometimes traumatic healthcare experiences and outcomes. There is a clear relationship between stigma and trauma. So when we are interacting with individuals, we want to remember that most people have experienced trauma. It could be personal trauma or generational historical trauma or the trauma of racism repeated throughout their lifetime, for example. People with substance use disorder are more likely to have experienced trauma, including in the healthcare setting, social service setting, criminal justice settings, pharmacy setting, etc. Recognize how trauma affects people. So trauma impacts physical health, neurobiology, and cognitive, social, and emotional functioning. And as I mentioned earlier in the presentation, what we perceive as, quote, high-risk behaviors, unquote, really can be a way of coping with trauma. So when we are interacting with folks, we have to remember that folks may have past histories of trauma and violence and layers of disadvantage and stigma that we may not be aware of. And all of that can influence the way that they engage with us in the role that we are in interacting with them. So we want to commit to not repeating trauma and think about using universal trauma precautions with everyone that we interact with. So special consideration with older adults is ageism and stigma. So older adults who use substances face an additional layer of stigma in the form of ageism. So a common belief is that older adults will not benefit from treatment. So this is an example. They've been drinking their whole life. They won't change now. It can also manifest in the form of accepting attitudes or denial of a possible problem. So they've been drinking their whole life. Why should they stop now? It's one of the last pleasures they have. Regardless of these beliefs, studies have shown repeatedly that older adults benefit from treatment of their substance use disorder if that is what they would like, is to be engaged in treatment. So what we say and how we say it matters. This was a study that was done a few years ago, and it's showing how important language is. So this was a study done by the Recovery Research Institute, and they basically gave one line to describe a hypothetical individual to participants in the study. One person was referred to as a, quote, substance abuser, unquote, so using old stigmatizing language. The other person was referred to as, quote, having a substance use disorder, unquote, so using non-stigmatizing person-centered language. They gave no additional information on these individuals. What they found was that the participants felt that the, quote, substance abuser, unquote, was less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, more likely to be blamed for their substance-related difficulties, and less likely that their problem was the result of an innate dysfunction over which they had no control, and they were more able to control their substance use without help. So you can see how powerful language is in affecting how people perceive that individual who uses substances or has a substance use disorder. And clearly, there was more empathy towards the person who had a substance use disorder. Here are just a couple of examples of best practice to avoid using stigmatizing language. On the left-hand side comes from the National Harm Reduction Coalition. This is just a snippet. There's far more detailed information on their website. So again, instead of saying addict, abuser, substance abuser, junkie, etc., person who uses heroin, person with a cocaine use disorder. So again, we're not defining the person by their substance use. We're recognizing their humanity first. And just like a person with any other mental health diagnosis, we are not making their diagnosis define who they are. The terms clean and dirty are ubiquitous in the substance use disorder treatment system, but they are very stigmatizing. So whether we're describing a person currently using substances or not using substances currently, or whether we're describing toxicology results, we should be very specific in our language and not use the terms clean or dirty. Because if you're clean now, that is making the assumption that you were dirty earlier. And we do not define other individuals with other health conditions as clean or dirty. So we should not be using that language with substance use disorder either. So ways to describe those situations instead are a person not currently using substances, or a person who's actively using substances, or an expected toxicology, an unexpected toxicology, an anticipated toxicology, an unanticipated toxicology, a positive toxicology, and negative toxicology. So again, using neutral language. On the right-hand side is emphasizing the point that we should be using strength-based language rather than deficits-based language. This particular chart was meant for written documentation, so charting. So when we chart, that becomes part of a permanent medical record. In the era of electronic health records, often part of that note is cut and paste and moved into a future note. So stigmatizing language can be carried over and over and over in a chart note. And what that does is that can potentially bias the next care provider towards that individual who's coming in for services. So if someone sees manipulative written in a chart, they're going to have a preconceived negative connotation of that individual. And so a strength-based way to describe that same quality is resourceful. So when we describe someone as manipulative, we think that they are trying to get something from us that we don't want to give them or don't think they deserve. A better way of seeing that is a patient is self-advocating, and describing them as resourceful really describes the same behavior, but not in a negative way. The other thing that we commonly see is with respect to substance use disorder is a person is suffering with substance use disorder or suffering with addiction. And that, again, takes away the autonomy of the patient. A better way is that a person is living with substance use disorder or is currently active with their substance use disorder or their substance use, or is experiencing substance use disorder. Again, it's using neutral language to describe the situation, not victimizing the individual. So what is trauma? And this is important, again, to understand with respect to our older adult population. So trauma is the exposure to actual or threatened death, serious injury, or sexual violence in one or more of four ways: directly experiencing the event themselves, witnessing in person the event occurring to somebody else, learning that such an event happened to a close family member or friend, or experiencing repeated or extreme exposure to aversive details of such events. So think about a first responder. So similar to the way that substances interact with the brain on a physiological and anatomical level, similarly, violence or trauma also causes similar changes in the brain, actually in different parts of the brain. It affects particularly the anterior cingulate cortex, the hippocampus, and the amygdala. So again, different areas of the brain than substance use specifically affects the brain, but causes similar effects. So you, particularly if someone develops PTSD, you get a trauma response. So that may involve flight, fight, or freeze, but it also changes the balance of neurotransmitters in the brain and causes just a heightened response. And so we need to be very cognizant of not triggering traumatic experiences in our patients when we're engaging with them. So what are some of trauma's effects? So it has behavioral effects. So some of those effects include lack of physical activity, smoking, using alcohol and other substances, or missing work. There are physical and mental health consequences. So these are just a few that are listed here: developing diabetes, severe obesity, depression, suicide attempts, sexually transmitted infections, so causing increased risk-taking behaviors, broken bones, so falls or other injuries, COPD, stroke, heart disease, cancer. And when we think about, again, interacting with our patients, and we think about trauma, and we think about all of the things that we've been discussing, we want to understand intersectionality and its role in identity, our identity, and our patient or client's identity, our oppression or our patient or client's oppression, and our privilege or our patient or client's privilege. So that individual in front of us may have many intersectional identities that we may or may not be aware of. This image on the right-hand side is showing a survivor and multiple situations that they've been in and how those identities impact how they will engage with you and the rest of the world. So we want to practice trauma-informed care. So what does that mean? The 4 R's of trauma-informed care are realizing the widespread impact of trauma, recognizing signs and symptoms of trauma in people, including our patients, our clients, their families, our staff, and our clinical team members, responding by fully integrating knowledge about trauma into policies, procedures, and practices, and seeking to actively resist re-traumatization. I mentioned taking universal trauma precautions. So that's assuming that all people have experienced trauma and interacting with all individuals using these precautions. We want to be able to adapt in a situation. So if we see that a patient is having a bad reaction or is experiencing or re-experiencing trauma from our interaction, we need to pivot and change what we're doing and what is happening. We want to not generalize one trauma is all trauma. Everybody experiences trauma individually. We want to anticipate shame and stigma. And we want to ask individuals, what happened to you, rather than what's wrong with you. So just a quick overview of harm reduction. which again is very important in our interactions with adults with substance use and substance use disorder. So first, the definition of harm reduction, which comes from the National Harm Reduction Coalition. Harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. It is based on a strong commitment to public health and human rights. Harm reduction, in theory, what is it? So the goal of harm reduction is to move people from the place where they are to their most realized, healthiest, and safest place. So for some people, that place will be abstinence, and it may be abstinence for all substances, but for many others, it is not abstinence. And abstinence from drug use is not an actual requirement for full participation in society. So we really need to be aware of what our patient or client's goals are. Harm reduction incorporates a spectrum of strategies that include safer use, managed use, abstinence, meeting people who use drugs where they are at now. Two basic components of harm reduction are pragmatism. So this means that the policies, strategies, and services that we offer are effective and evidence-based, and respect for the human rights of people who use drugs. What are the guiding principles of harm reduction? Having a non-judgmental approach. It is evidence-based, feasible, and cost-effective. It's acceptance of behavioral change, or any change for that matter. So no matter how small it seems, as an incremental process. It requires meaningful participation by people who currently use drugs, by people who previously used drugs, and stakeholders in shaping policies and practices around substance use. It focuses on enhancing quality of life. The focus is not on abstinence. It doesn't mean that it excludes abstinence if that is the goal of the person that you're engaging with. It recognizes that there are complex social factors at play. It recognizes the real harms of substance use on individuals, families, and communities. It wants to empower people who use drugs in reducing potential harms of their substance use. And it is a commitment to defending universal human rights, which includes the human rights of people who use drugs. So how do you have meaningful discussions around substance use, and what are practical interventions for older adults? So there is a role for the care team, brief intervention following a positive screening. Be empathic and be curious. Note changes in the individual you're working with as they could be indicating a problem. Listen. Staying quiet is a learned skill. Many of us, particularly physicians, and I'm saying that because I am one, and so I know, talk too much. And so we really need to learn to listen. Often, if we allow for quiet, people are more likely to share. If we have concerns, we want to state our findings. So we want to do education regarding problematic use and substance use disorder. So if a person screens positive for risky alcohol use, then you can provide psychoeducation. You can go over those NIAAA guidelines that we went over earlier for older adults. You can share with them what a standard drink size is. Many people are completely unaware of that information. You can advise, but do so in a non-judgmental way, and avoid being prescriptive, accusatory, or declarative, and refer to outside support if necessary and with the person's consent. Remember your general motivational interviewing strategies. So give advice, try to remove barriers, provide choice, decrease desirability, practice empathy, provide feedback, clarify goals, and actively help. I've listed the stages of change on the right-hand side. So pre-contemplation, contemplation, preparation, action, and maintenance. And when we put motivational interviewing into practice, what does that look like? So what does expressing empathy look like? It must be very difficult for you to talk about your heroin use and how it has affected your relationship with your daughter. Develop discrepancy. It sounds like on the one hand, you want to stop using so you can see your daughter, but on the other hand, you like the way heroin makes you feel. So for an older adult, you may substitute granddaughter or grandchild in that phrase. Adjust to resistance. I hear you saying that abstinence isn't for you right now. Support self-efficacy and optimism. You have obviously given this a lot of thought and have some great ideas on what may be useful to you. Avoid argument and confrontation. I don't think you failed because you are here and you want things to be different. So when we think about diagnosing substance use disorder, we use DSM-5 criteria to do so, but there are many additional considerations with respect to older adults. So I'm not going to go through each of these examples, but I'll just read a couple of them. So for DSM-5 criteria for substance use disorder, there is craving or a strong desire to use the substance. So the consideration for the older adult with respect to that criteria, it is the same as the general population. Older adults with entrenched habits or entrenched use may not recognize cravings in the same way as the general adult population. Another criteria, a substance is often taken in larger amounts or over a longer period of time than was intended. So with respect to the older adult, cognitive impairment can prevent adequate self-monitoring. Substances themselves may more greatly impair cognition among older adults than younger adults. So this has some good information on some things to consider with respect to older adults and diagnostic criteria. What about treatment services for older adults? All levels of treatment services are available to older adults. According to SAMHSA, the least intensive treatment, such as outpatient programs, is likely to be the most effective for older adults. So you want to take that into consideration when working with older adults. So some programs do offer, as we saw, age-specific tracks for older adults, but we saw that that is not super common. So again, we want to try to tailor our referral sources the best we can to meet the needs of older adults that we're working with, but recognizing that that may not be available in your community. Medications for addiction treatment, including medications for opioid use disorder and medications for alcohol use disorder, are available in all treatment services. Engaging in other adjunctive services, such as counseling, should not be required in order to be prescribed medications for opioid use disorder, such as methadone or buprenorphine. And research repeatedly has demonstrated that medications for opioid use disorder are an effective standalone treatment for opioid use disorder. What are some age-specific treatment tips? So some age-specific tips with respect to older adults. So older adults with substance use disorder report that they benefit from smaller groups than that focus on age-specific topics than all age groups. Older adults benefit from being treated with individuals their same age that are talking about other age-related issues. Older adults engaged in the program have repeatedly stated that they have felt like mom or dad in the rooms when they are in treatment with younger patients. They are focused on helping others and often report that their own needs aren't met because they're helping others. What are some specific or special groups that may be needed for older adults? For patients who experience childhood trauma, a trauma survivors group may help older adults with substance use disorder have a safe place to discuss the impact early childhood trauma had on their later life, substance use disorder, mental health, or physical wellness. Consider an age-sensitive approach. So having age-related materials in the waiting room helps older adults feel more comfortable in the waiting room. Large print materials should be available because, again, there may be visual impairments with some older adults. Having accommodations on the first floor for non-ambulatory patients may also be a necessity. Providing transportation to pick up patients as patients may not be able to take public transportation due to any physical limitations. Stigma is very important when considering engagement and retention of older adults with substance use disorder who may feel ashamed of their substance use or substance use disorder or their mental health diagnoses. Finding meaning and purpose in later life is also important. Often older adults do not feel anyone needs them anymore and that they don't have anything to do that's meaningful in their life. Increased depression, higher risk for suicide, and increased substance use are all tied into the lack of meaning and purpose. Also, lack of connection with others. Then there are considerations with respect to community linkages. So also critical to working with older adults with substance use disorder is the connection of services in the community. The geriatric addiction medicine provider can act as a liaison, helping the older adult with substance use disorder to receive benefits and connect with services in the community. When we think about older adults and substance use disorder treatment services in rural communities, again, there are often very specific concerns that a community may want to consider that have to do with accessibility, that have to do with connections to other services in the community, that have to do with anonymity, that have to do with acceptance, meaning cultural responsiveness within a community. So again, a lot of detail on this slide. So I recommend that folks look at this in detail. I'm not going to go over the specifics. This also comes from a UN document that came out in 2017. So this was just one diagram from a multi-page document that came out on looking at specific needs in rural communities for substance use disorder treatment. When we think about medications for opioid use disorder and the options, let's talk about that for a few moments. So what are our goals for medications for opioid use disorder? The biggest goal is to decrease risk for fatal and non-fatal overdoses, eliminate opioid withdrawal syndrome, decrease opioid cravings, which again lead to return to use, increase patient functionality, and then normalize brain anatomy and physiology, and decrease transmission and acquisition of viral infections. So those include hepatitis B, hepatitis C, and HIV, and also infection complications such as abscesses, cellulitis, endocarditis, and osteomyelitis. Looking at the 3 FDA-approved medication options for the treatment of opioid use disorder, first we have methadone, which is a full agonist opioid. This must be dispensed from an OTP or a mobile medication unit. Methadone is associated with both decreased opioid-related overdose mortality and all-cause mortality by at least 50%. It's very unusual to have a medication that decreases your mortality risk by 50%. The number needed to treat, so the number of individuals needed to treat is 2.3 to receive a decreased mortality effect at a large effect. For buprenorphine, it is an opioid partial agonist. It is a Schedule III drug, so it may be prescribed with refills. It no longer requires a DEA X waiver to prescribe. It is also associated with decreased opioid-related or overdose mortality and all-cause mortality, again, by more than 50%. It also is associated in one study with decreased suicide mortality at over 65%. The number needed to treat with buprenorphine is less than 3 for prevention of 1 death due to opioid use disorder. For extended release naltrexone, it is an opioid antagonist. It is not a controlled substance. It is not associated with decreased mortality, either opioid-related or overdose mortality or all-cause mortality. The number needed to treat is 6.7 individuals needed to be treated to have 1 person remain in care on naltrexone. So again, very different. As you saw, the number needed to treat for both buprenorphine and methadone was very low to prevent death. As opposed to naltrexone, you needed a more significant number of individuals to keep 1 person in treatment, not associated with mortality. This is a head-to-head comparison of methadone versus buprenorphine versus naltrexone versus no treatment. Again, showing that both methadone and buprenorphine are associated with all-cause mortality reduction and opioid-related or overdose mortality reduction, about 50% for each of those, for both of them. And there was no association between naltrexone and either overdose mortality or all-cause mortality. This is the study that I mentioned that showed the same information. So that methadone and buprenorphine were associated with decreased external cause and all-cause mortality, but buprenorphine was also associated with decreased suicide mortality. Naltrexone was not associated with either reduced suicide mortality or all-cause or external cause mortality. So what about harm reduction and alcohol use? Often when we hear about alcohol use, we only hear about abstinence-based goals, but we really need to be realistic when we're having conversations with our clients or our patients and listening to what they hope to accomplish in treatment. So in this particular study, 39% of patients wanted total abstinence. So I want to quit using alcohol once and for all. 29% wanted to achieve controlled drinking. I want to use alcohol in a more controlled or managed manner. 32% wanted conditional abstinence. I want to be abstinent for a period of time, after which I will make a new decision about what I want to do about my alcohol use. On the right-hand side is showing some alcohol harm reduction strategies. So there are both abstinence-based strategies and non-abstinence-based strategies. Some abstinence-based strategies include going to what we formerly called detox, so withdrawal management services, residential treatment services, sober living environments, 12-step programs, and mandated treatment. Non-abstinence-based alcohol harm reduction strategies include sobering centers, wet shelters or wet drop-in shelters, managed alcohol programs, moderation management of alcohol, housing first, or damp or wet housing programs. Now, in either of those situations, whether it's abstinence-based or non-abstinence-based, pharmacotherapy or medications for alcohol use disorder treatment can be utilized. So what are the pharmacotherapy options for alcohol use disorder? There are 3 FDA-approved medications. Disulfiram, which was approved in 1949, its mechanism of action is as an aldehyde dehydrogenase inhibitor, so it causes an unpleasant physical reaction when somebody drinks alcohol. This is the least efficacious of the FDA-approved medications for alcohol use disorder. There is naltrexone. This is an oral formulation that was approved in 1994. There is also an injectable formulation that was approved in 2006. Its mechanism of action is as an opioid receptor antagonist. So you may ask, so how does it decrease someone's drinking if it's an opioid receptor antagonist? When we experience something pleasurable, we release endogenous opioids. So these are opioids that our body makes, not that are introduced externally. As an opioid receptor antagonist, it blocks those endogenous opioids from attaching to the opioid receptor in our body and giving us a pleasurable sensation. So essentially, this works by decreasing the pleasure that someone would receive from drinking. So therefore decreases cravings for alcohol. So in a Cochrane review, the number needed to treat with naltrexone to decrease heavy drinking was 12 individuals. To decrease heavy drinking in 1 individual. The number needed to treat to decrease daily drinking in 1 individual is 25. Then the third medication is acamprosate, which was approved in 2004. It's also an oral medication. The mechanism of action is not well understood, but it is an NMDA glutamate receptor antagonist. In the Cochrane review, the number needed to treat for reducing the risk of any drinking in 1 individual was 9. There are many evidence-based psychosocial interventions for alcohol use disorder. I've listed many of them here. I'm not going to go through these individually, but again, in support of medications for treatment of alcohol use disorder, there are many, many evidence-based psychosocial interventions. As you may have noticed, the medications for the treatment of alcohol use disorder are not as efficacious as the medications we have to treat opioid use disorder. Specifically, I'm speaking about methadone and buprenorphine. When we think about overdose prevention, we want to be sure to advise individuals who are are using about the Never Use Alone hotline. So this is a hotline that people can call that is serviced by volunteers 24/7. And the person remains on the line with the individual from the Never Use Alone hotline while they're using alone. And if they become unresponsive, then that person activates EMS to prevent an overdose. When we think about overdose prevention, we also want to remember naloxone. So naloxone will reverse the opioid component of an overdose. So anyone who is actively using substances, particularly when we know that fentanyl and other illicitly manufactured opioids, highly potent synthetic opioids, are being added to other substances besides opioids. So they're being added to methamphetamine, they're being added to cocaine. There's also co-use of opioids with other substances. We don't want to make an assumption that someone who is a stimulant user does not need naloxone. So anyone who's actively using substances other than cannabis and alcohol should be prescribed naloxone. Obviously, if we know that someone is co-using opioids with cannabis or alcohol, then they should be prescribed for those individuals as well. There are many ways to access free naloxone these days. We anticipate naloxone to be over the counter, at least one formulation in the next couple of months. So we want to be sure that everyone has access to naloxone and knows how to use it. The other thing I want to mention, I don't have a slide about this, but I want to mention that polysubstance use is the most common type of use, and polysubstance overdose is the most common type of overdose. So naloxone is always an important first tool in the toolbox when you are responding to an overdose. So you want to give a dose of naloxone, wait 2 full minutes, and give a second dose of naloxone. But if that individual is not responding to naloxone, the answer is not to continue to give naloxone, but to recognize that there's likely another substance on board that is non-responsive to naloxone because it is not an opioid. One example would be xylazine, which is a sedative that causes profound central nervous system sedation and also impacts breathing because the tongue obstructs the back of the throat, so physically prevents breathing. So you could give somebody multiple doses of naloxone, that's not going to do anything in an overdose that's with fentanyl and xylazine. So in any situation where a person is not responding to the first 2 doses of naloxone, you should have already activated EMS, but that individual needs support breathing. So think about head tilt, chin lift, think about rescue breathing. If you have access to an ambu bag or administration of oxygen, you want to utilize those strategies because, again, polysubstance use is the most common type of use. Polysubstance overdose is the most common type of overdose. Naloxone will only reverse the opioid component of the overdose. So next, recovery is individualized. So what is recovery? It's a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. You can see that that definition does not include the word abstinence. Individualized recovery is what we're shooting for. That may include abstinence to all substances. It may include abstinence to some substances. It may just include less chaotic use for other individuals, but not abstinence. So it's really important when we think about recovery that we make sure that we're discussing on an ongoing basis the goals that our clients or our patients that we're working with have. Some of the components to think about in that process of change are health, so overcoming or managing their health conditions or symptoms. So that might mean that that person gets access to Hep C treatment and cures their Hep C, or they get access to antiretroviral medication for their HIV and instead have managed HIV with an undetectable viral load. It includes home, so having a stable and safe place to live. Decreasing or ceasing use is very low on the hierarchy of needs of someone who is living in an unsafe situation or who is unstably housed or unhoused. Thinking about purpose. So for people, again, to have purpose in their life, so meaningful daily activities and the independence, income, and resources to participate in society. If someone doesn't feel like their life has a lot of purpose, then what is the meaning of stopping or decreasing use? And lastly, community. So connection is the opposite of addiction. So thinking about relationships and social networks that are healthy, that provide support, friendship, love, and hope to the individual that we're working with. On the right-hand side is a social network map for older adults in recovery. And you can see that there are many components: friends, neighbors, church or other social groups, service providers, recovery group members, work or school companions, if applicable, and then family, household members, or others. So briefly, I'm going to go over a conceptual framework of a recovery-oriented system of care. This comes from that same United Nations document that I mentioned a few slides ago. Again, showing the complexity of recovery as the complexity is of the influences on an individual and developing substance use or substance use disorder. So here with the community or individual or family in the middle, it's showing the layers to support that patient from outside. So there's a layer of services and supports, which can include things such as peer supports, housing, transportation, spiritual supports, legal supports, crisis intervention, care management, etc. Then there's another layer of coordinated systems. This can include the child welfare system, the housing system, the Veterans Affairs system, criminal justice system, Indian health services, primary care, mental health treatment, substance use disorder treatment. And then there are outcomes. So looking at the outcomes, we're thinking about recovery, we're thinking about health and wellness, and we're thinking about resilience. And there are multiple factors that play into that layer as well. So I really encourage folks to look at this document. It's a really interesting overall document and has some excellent graphics and explanations on how to think about a recovery-oriented system of care, as well as other aspects of substance use disorder treatment. Lastly, I'm going to go over conclusions. So as we've seen, substance use disorders, and overdoses are common among adults aged 55 and older. We want to normalize asking about substance use in our clinical practices or the locations in which we're engaging with clients, and be sure to use validated screening tools. There are evidence-based best practices for addressing substance use and treating substance use disorders, including in older adults. Stigma towards substance use and people who use substances is still commonplace in healthcare settings. We want to be mindful of the language that we use when discussing and documenting substance use. Develop collaborative relationships proactively with your local substance use disorder prevention, harm reduction, treatment, and recovery providers to assist in future care coordination efforts. So it isn't a scramble when you need to link to someone with a variety of services. Rural settings face unique issues and complexities in addressing substance use and substance use disorder among older adults. So thank you so much for coming. I've listed some additional resources here with respect to older adults and substance use disorder. And I have put my email, kelly.ramsey@oasis.newyork.gov. I'm always happy to answer anyone's questions. I'm going to toss this back to Dean.
I want to thank Dr. Ramsey for joining me today. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation, including suggesting any future topics for Learning Thursdays. Once again, thank you for joining us and keep up the good work.